Hello everyone, I'm Anna Mercante and I'm a child neuropsychiatrist. Today, I would like to present to you the results of our recent publication on sleep problems in pediatric palliative care. I will start saying that sleep problems have been identified as a common and significant contributor to symptom burden in children and adolescents requiring PPC. According to the few available reports, the prevalence ranges from 50 to 80%. However, unlike other aspects of PPC, sleep has received little attention. Therefore, sleep problems remain poorly addressed in this population, profoundly affecting the entire family's quality of life. In this context, sleep problems more commonly develop as a consequence or complication of the underlying condition and generally result from a combination of intrinsic and extrinsic factors. In addition, no guidelines or good practice are currently available, resulting in few palliative care providers pursuing sleep symptoms despite their potential repercussions. To address this critical gap, we gather an international and multidisciplinary group of experts in pediatric sleep and PPC to provide recommendations on the definition and management of sleep problems in this setting. A two-round Delphi approach was adopted to develop consensus. As you know, the Delphi method is a systematic technique for reaching consensus when limited or conflicting evidence exists. As shown here, it consists of an iterative process comprising multiple rounds of control, individual, and anonymous feedback from a group of experts through structured questionnaires. In our study, a steering committee of 10 experts, 5 pediatric sleep experts, and 5 PPC experts was selected to review the literature and write a list of statements, while 72 experts from different disciplines worldwide were included in the panel and participated in the vote. As for the results, after 2 rounds, we obtained a high level of positive consensus in the 3 macro areas of definition, assessment, monitoring, and treatment of sleep problems in PCC in both round 1 and round 2, with the production of 53 expert recommendations. Unfortunately, today we don't have time to analyze each statement, but let's have a look together to some of the most significant ones and their major complications. In the definition section, the recognition of a sleep problem's multifactorial nature reflects the multifactorial complexity of the PP setting and calls for a thorough and repeated assessment of sleep disorders, keeping in mind the possibility of their co-occurrence in the same child. It also established the active involvement of the pediatric sleep specialist in their care plan when needed. More, inadequate pain control was confirmed as a particular risk factor for sleep. Therefore, whenever a sleep problem is reported in these patients, questions should be raised about the presence of pain and proper evaluation to investigate it should be performed. Likewise, an adequate follow-up is warranted if pain treatment is initiated to ensure its efficacy. In fact, in these children, addressing sleep without addressing concomitant pain may not be effective. Notably, it was strongly acknowledged that also most parents and caregivers of children needing PPC experience poor sleep and hence require treatment. Moving to assessment and monitoring, it was underlined the importance of investigating the psychological profile to address sleep disorders adequately, consistently with age and cognitive level. More, the overlap of a rationale for referring this patient for an in-lab sleep study was firmly established. This may represent, in fact, an impractical option and align with the overall non-invasive treatment goals. Moreover, access to such expertise is always not common. The panel was less certain that other objective non-invasive measures, such as actigraphy or video sonography, could be helpful, but promising data are available in the literature. So these techniques should be considered for both clinical and research. Finally, regarding treatment, prompt accurate identification and management of children's sleep problems were defined as an essential component of a gold standard PPC because of the significant potential impact of poor sleep on both children and caregivers. This should be pursued through a multidisciplinary approach combining both pharmacological and non-pharmacological intervention. Medication specification was less harmonized, with a consensus on limiting the use of benzodiazepine and antihistamininergic. Also, consensus of melatonin was strong, with some cautious. We know, in fact, that manufacturing and sales are regulated differently worldwide, and over-the-counter formula contents can also differ greatly from what is reported in the label, jeopardizing its efficacy but above all its safety. Since many medications, mostly unregulated, are now available for international purchase online in countries where melatonin is prescription only, this acknowledgement is crucial for clinical appliance, with consequences beyond the pediatric palliative care setting. Last but not least, a number of other potentially useful non-pharmacological interventions were provided with different level of agreements, as for example, optimizing means, drug administration, and timing of rehabilitation session, or for example, as developing a free sleep routine for children suffering from insomnia. Again, environmental strategies such as noise or light control and room privacy were suggested to improve the quality of sleep in this population. This concludes the intervention of today. I'm leaving you with these take-home messages that underline the need for global guidance for the assessment and management of sleep concerns in children and adolescents with palliative care needs to reduce the associated physical and emotional burden. And I'm happy to say that based on the information that we've gathered from this study, guidelines are currently being developed to promote sleep health and improve the quality of life. I want to thank you all for your attention, and I want to thank you, the ESRS Digital and Communication Committee, for having given me this opportunity. If you have any questions, please write to me.